You're part of a great organization, and you're all going to have keep up, like stay with it, stay in contact with people from AOCPMR for now and when you get into residency. So a little bit about my path to PM&R. Like I said, I grew up on Long Island. I was a lacrosse player growing up. That's the only sport that we're pretty decent at on Long Island. We're pretty bad at everything else compared to the rest of the country. Football and baseball and everything aren't too great on Long Island, but our lacrosse is definitely pretty solid. I wasn't very good. I was good enough to play at a Division III school. And when I say play, I mean sit on the bench for most of my career. Through that, I got into CrossFit and weightlifting. I competed in Olympic weightlifting for a few years in college and at the beginning of medical school, and I still train the snatch and the clean and jerk. I actually went and got through that my weightlifting certifications and became a trainer at a place called Revolution Athletics back on Long Island, where I was training youth athletes and collegiate and a few pro athletes as a strength and conditioning coach. So when I was at F&M and doing all these things between lacrosse, weightlifting, and coaching, I was really trying to figure out what my next step was going to be and what I wanted to do following undergraduate. So, kicked around ideas of going to MD school, going to chiropractic school, going to physical therapy school, going to podiatry school, or becoming a full-time strength and conditioning coach or CSCS. And I had an amazing, and this is where kind of the key of this whole talk comes along. I had an amazing mentor at Franklin and Marshall College. It was our health science advisor. And she said, why don't you check out this, this osteopathic medical school? And PCOM was coming to campus to give a presentation right around that time. So I made the decision to apply to DO school. I went full throttle for it once I figured out kind of what the field stood for. The focused on neuromusculoskeletal medicine throughout medical school. And they applied to only DO schools, and was fortunate enough to get into a few, and fortunate enough to end up at PCOM. When I started my first year at PCOM, we found PM&R pretty early along the way. As a first year medical student, I was walking around the fair, the activities fair, and figuring out what clubs I wanted to join and what was interested. And there was this guy right up here in the left corner. This is Dr. Brandon Bart. He's a PGY4 over at Temple Moss Rehab. He was a second year medical student at the time. I was standing alone by this poster with a bunch of people, playing sports, and, whether they were on a prosthesis or in a wheelchair and all this cool stuff. And I said, what is this all about? And he brought me along to a few physiatry events early on as a first year. And that was it. I was sold. After my first medical student fair at Kessler up in Jersey, I knew I wanted to be a physiatrist from there on out. And then I already talked about Dr. Elwert. This is Dr. Levin. He's an OMM doc at PCOM. He's a physiatrist trained at Jefferson. And then this is Dr. Jim Eubanks, who I met, along the way. And these people really pulled me into the field of PM&R and made me want to be a physiatrist first. And along my way of finding my path to sports medicine. As I talked about along the way, AOCPMR, I got involved right away as a first year, went to my first AOCPMR conference as a first year medical student. And that really kindled the flame for PM&R. And then many of you probably have heard of PM&R Scholars. It's an organization they've been involved with for a long time, helped out off the ground in a lot of ways. And the same thing, the mentors that I met there really pulled me deeper and deeper into the field of PM&R. So why sports medicine? That's what we're here to talk about. Why is sports medicine a great career path for physiatrists and a great career path for anybody interested in musculoskeletal medicine? I talked about my athletic history. I always knew that I wanted to work with musculoskeletal conditions in some capacity, whether it was going to be a physical therapist, chiropractor, podiatrist, or strength and conditioning coach. And when I figured out what a primary care sports medicine doc did, I was sold. I never wanted to be a surgeon. I never wanted to stand at a table for hours and do all these crazy, amazing procedures that orthopedic surgeons do. But I knew I wanted to work with the MSK population, the population of pain and population of injured athletes. Why is sports medicine so cool? There's so many unique opportunities and unique settings to practice with unique people, is the way that I'll put it. This picture up top of me and Dr. Sampson and Dr. D, who's a local doc here. Dr. Sampson's the head medical doc for All Elite Wrestling. I'm a huge wrestling nerd. This was like a lifetime dream of mine. I got to meet CM Punk. I got to meet, the Big Show. I got to meet Mark Henry, the world's strongest man. And that type of opportunity is what you get in the world of sports medicine. I got to do some OMT on these professional athletes. It was a really, really cool opportunity. There's so much variety in presentation of patient, the different patients that are going to come walk through your door and the things that they're going to complain about. variety of their rehabilitation needs, variety of their treatment needs, the things that you're going to be able to offer them, and variety of treatment timeline. You might have people that, have a 5K to run in the next 3 days, or you're going to have people that just finished their season. You have a little bit of time to play with. So it poses different challenges and different opportunities for treatment. There's a true blend of anatomy and kinesiology. As a strength and conditioning coach, I'm an anatomy and kinesiology nerd. I talk to my friends from college more about the biomechanics of the spine than we talk about anything else, and their families that they're raising, because we're that nerdy about it. And sports medicine has a true blend of that when you start talking about different mechanisms of injury and the things that you start seeing that wander into the clinic or come off the sideline. There's a focus on lifestyle medicine. Athletes want to live healthier, but even the people that roll into your office, if they're getting treated for osteoarthritis, there's the possibility to talk to them about changing their lifestyle and really affecting their health for the long term. There's opportunity to apply cutting edge technology. I'll talk a little bit about fancy procedures that are coming along the way. And there's a need for quality research. There's a lot of research out there that's not that great. And there's a lot of research out there that is great and really budding. And it's one of the things that I became really passionate about at the tail end of my medical school career. And if you told me that when I was a second year undergraduate student, when I was a sophomore in college, that I was going to be a research nerd and applying to our research track and writing grants, I would have laughed at you. But that's where I am today, and that's become a long part of my career goals. So how do we get there? How do we get to being a sports medicine doc? As I said, there's more ways than one. If you saw this episode of I Think You Should Leave, he pulls a push door until it opens. So there is ways to get into the field, no matter which way you decide to take. And some ways are harder than others, to be completely honest. But there is more than one way to get to the field. So we talked a little bit about the path and how long it takes. So I'm not going to belabor this point. But residency does vary. When we're going to talk about the different residency pathways to get to sports medicine fellowship, there is a varied path where, if you do family medicine, it's going to be 3 years. Some emergency medicine residencies are 3 years. Pediatric residency is 3 years. IM is 3 years. So PM&R is the longest residency training that it's going to take you to PM&R to sports medicine, aside for some of the 4 years emergency medicine residency programs, which do still exist. So what are the options? If the end goal is doing a primary care sports medicine fellowship or a non-operative sports medicine fellowship, how can we get there? And what are the benefits of taking those different routes? So you have family medicine, which is kind of the bread and butter way to get there. That's the people that got there first were the family medicine docs. There is definitely by far and away, when you look at the number of fellowship slots in the country, most of them are available for family medicine, and most of them are reserved for family medicine through family medicine departments. There's different reasons for that. And we could talk a little bit about that later, but that's truly, the easiest, I won't say the easiest, but the most opportunities for fellowship slots is through family medicine. Benefits of doing family medicine is that primary care experience. You know how to take care of a lot of the athlete's problems other than their musculoskeletal conditions and their concussions. Whether it's, the common cold and STD, whether it's their diabetes, there's type 1 diabetics that play sports at every level. You could really get a good base of that primary care experience. You could get there through emergency medicine, and that the benefits of that are definitely the emergency triage. I would argue that the emergency medicine docs are some of the best sideline docs, because when something goes down on the field, they're reacting like an emergency medicine doc. They're used to the split-second decisions that are made in emergency medicine. That's a great route to the field as well. Internal medicine is similar to family medicine. You have that primary care experience. I don't know a ton of people that have went into sports medicine from internal medicine personally, so I can't speak too much about it. But there's my poster at AMSSM at one of the sports medicine conferences was just next to the primary care sports medicine fellow from HSS, which is the #1 orthopedics hospital in the world, and he was IM trained. So it's definitely a pathway and a foray into the field of sports medicine. Obviously, there's PM&R, and we'll talk a lot about this for the rest of the talk, why PM&R is an awesome way to get into the field. The MSK and neuro experience that we get, I would argue, is second to none. And we do get a very strong medicine base, which we'll talk about in a little bit. And then pediatrics is also a way, and you get really great experience with the pediatric and adolescent athlete, which is actually the population that I see myself working with in the future. It is another way into the field, and there's a lot of spots that are reserved for just pediatrics. So I'll just give a quick plug. The AMSSM, the American Medical Society for Sports Medicine, this is kind of the home base for primary care sports medicine providers. Just like AOCPMR is the home base for osteopathic physiatrists in the US. They actually have a fellowship list. I'm not sure if you have to be a member to access this list, but you could look at you could plug in the different specialties and see which fellowships are available to the like for PM&R sports medicine fellowship versus a family medicine sports medicine fellowship. You can apply to many of the other specialties. So like I do plan on applying to some of the family medicine, sports medicine fellowships. You just need to make sure that the easiest way to find out if they take PM&R applicants is to look at their former fellows, but they also need to have a faculty on staff in the department. And that's because mandated by the ACGME, you have to do a half day a week of your previous specialty in clinic. So like for us, we would have to do a half day of physiatry, whether that's doing EMGs, whether that's doing consults. It has to be, you know, a half day a week of true physiatry. The other thing is some of the times that programs can't get funding for a fellow from a different specialty. And that's the reason why they don't take certain applicants. And that's not because they think that they're poor applicants. It's just that the way that their programs are set up and the way their funding for their program is set up doesn't allow it. So this is a great resource just as a starting point. If there is a fellowship, you know, in a specific area of the country that you're interested in, I recommend looking at it. And if you're really geographically tied down for, you know, reasons with kids, significant others, family, you know, whatever, it's a great way to see what's available in your area. And then, you know, broaden your search from there. Go take a look at the actual program websites and who they have as their fellows. The other thing is there's different paths out after PM&R. You know, if sports medicine doesn't end up being for you and you want to do MSK related stuff to PM&R, you know, say you go through your physiatry residency and you fall in love with more of the spine stuff or the EMG stuff, or if you want to just get right to work, there are options. So there's ACGME sports medicine fellowships, which is going to be my focus today. There's interventional spine and MSK fellowships, which are NASS accredited, which are popping up at major institutions all over the country. You know, University of Pennsylvania, University of Utah, Emory, Vanderbilt, big time institutions do have these fellowships available to you. Some people will call them sports and spine fellowships. They're awesome. And in terms of procedural training, they're really impressive. And then there's pain medicine where you're going to get more of that, those spine procedures, those more advanced procedures like spinal cord stimulators, which you would also get in the interventional spine. And chronic pain management more. The other option is to go right to work. We had somebody graduate our program last year, Dr. Jeff Smith, who went right into practice, you know, a month after graduating residency, and he's doing ultrasound guided injections, diagnostic ultrasound, he's doing spine injections, and he's doing EMG right after finishing PM&R residency. So that is absolutely an option. And there's not only one path to accomplish your goals, depending what your goals look like. All right, so I know that was a lot of information. Now we'll talk a bit about specifically being a sports med physiatrist and, you know, why I'm here and why I want to be here. So the sports med physiatrist, when we start talking about residency training as a physiatry doc and how that relates to being a great sports medicine doc, the first thing is we have a strong medicine base. When you have to do an intern year as a physiatry applicant, whether you do a categorical program like I did, where it's attached to your PM&R residency, and then whether you do a transitional year or a preliminary medicine or surgery year, you're going to get a really strong medicine base. I mean, I was taking care of COPD patients. I was taking care of heart failure patients. I was taking care of patients in DKA. I spent time in the ICU, and you all will too. It's one of the toughest years of your life, but you learn a ton and you get really comfortable being uncomfortable, and you find out your limits and when you need to ask for help, which is a really important part of building that strong medicine base. And that, you know, it's a great year for growth, and it's really important if you want to be a sports doc to be able to recognize these problems and you know, handle the basic ones, but be able to know who to ask for help when things get crazy. It's also extensive neuromuscular training, you know, everything from our inpatient rehab units to outpatient clinics, pain, EMG, neurology, neuro rehab and sports medicine outpatient clinics. You're seeing everything. You're seeing every type of neuro and MSK diagnosis under the sun. So it's a really great opportunity to get that depth and breadth of neuromuscular medicine. Just today, you know, I was treating a patient with like musculoskeletal driven neck pain on our SCI unit. I did some OMM. That was a lot of fun. I don't get to do OMM all the time, but it was a lot of fun doing that today. You also get great procedural training in residency. I'd argue this is one of the strongest things that we have that some of the other specialties don't have in their residency training. Ton of ultrasound guided injections, ton of spine injections and EMGs. We actually are required to do more EMGs in residency than neurology residents. So we get a really, really strong basis and understanding of these. And it does vary residency program to residency program. But on average, we're really rocking with the procedural training and what we get to see. We also get diagnostic ultrasound training. This is what I'm doing my research on. This is what I'm super nerdy about, where it relates back to my anatomy and my anatomy and kinesiology background. Diagnostic ultrasound is awesome. If you haven't got the chance to see it yet, I highly recommend spending the time with a sports doc or an MSK doc that does MSK ultrasound at a pretty high level and see all the really cool stuff that they can do. There's some awesome videos online to check this out and kind of get a basic understanding of what the applications are. But just some of the positives and negatives. Ultrasound's cheap. You could use it in real time. It's dynamic and portable. It's a direct extension of the physical exam. I've gotten to do ultrasound on the sideline of football games, the sideline of hockey games, and you really get to look at things right away. If you think somebody had an MCL tear, you could pick that up pretty proficiently right on the sidelines, or something like a finger fracture or an ankle fracture. I've been able to pick up with ultrasound on the sidelines as well. So obviously no radiation. It's got great resolution for superficial structures. Some of the newer machines, it is crazy the stuff that you can see with the newer, more intricate machines. And it's great for procedural guidance, obviously, with that dynamic capability. The negatives, it's poor intra-articular in deep use. Some of the deeper structures are really hard to visualize, and you can't see past bone in most circumstances. There's less acceptance among other providers, although that's changing a little bit. There was this interesting debate at AMSSM about doctors or orthopedic surgeons operating on an ACL with just ultrasound findings and not or the UCL for Tommy John surgery with just an ultrasound and non-MRI. And there's a surprising amount of people that raise their hand that say that they work with orthopedic surgeons that will operate just based off of their ultrasound findings, which is really cool. And you can triage surgeries a lot quicker that way. I put in quotes here, it's provider dependent. It's definitely provider dependent. It takes a lot of practice to go good at it. And that takes a lot of time in our training. And, you really, if you want to be good at ultrasound by the time you're done with your physiatry training, you're going to have to spend a lot of extra time, in your residency lounge or wherever your ultrasound machine is housed to practice. It's not something that you're going to learn just in the clinic. So what about MRI? What's the argument between ultrasound and MRI? And, why is MRI better in some circumstances over ultrasound and vice versa? So as we talked about, MRI is way better for the deeper views and intra-articular structures. It's got wide acceptance as the gold standard for a lot of conditions. If you pick up an ACL tear on MRI, I don't think you're going to find an orthopedic surgeon that's not going to operate if it's the right patient. There's less variability. You can argue in terms of reader, but we'll talk a little bit about that in a second. Kind of negatives, it's expensive. It's very expensive. There's a delay in diagnosis, and in some circumstances, it's difficult to obtain. For some of our, non-athletic population or population that's not in high school, collegiate, or professional sports, it's taking them sometimes 3-4 weeks to get scheduled for an MRI. So you're really delaying that diagnosis, and it is not the easiest to obtain compared to ultrasound. The other thing is MRI is definitely provider dependent. When you talk about some of the more advanced conditions that you're diagnosing, like one of the ones that comes to mind is like adductor erectus tendinopathy, or a lot of people call it core muscle injury. That requires a special sequence to order, and it's not easily readable either. So it's definitely provider dependent, and there's amazing musculoskeletal radiologists out there that can read these things, but it's not. Like, people act like you put an MRI into a machine and you get an answer, and that's not true. It's definitely reliant on the radiologist that's reading it, and your ability to read it yourself, because a lot of you will get very good at reading MRIs as well. So what does life look like? As a sports medicine doc, you're done with your training. Well, what does your day-to-day look like? Or what is your day-to-day going to look like when you're on sports medicine rotations in residency? So the first thing is clinic. These are two pictures of our clinics here at UPMC. This is the Lemieux Center in Cranberry. This is the Freddie Fu Sports Medicine Center at the Rudy Sports Complex, right next to the Steelers practice facility. Your clinic day, a lot of times, if you're a physiatrist, it can be as busy or quiet as you want to make it. There's some academic physiatrists that are sports medicine docs that, see 10 patients in the morning, 10 patients in the afternoon. There's some that see double that. It really depends on the flow of your clinic and your clinical staff. And anything can really walk through that door at any time. So it's interesting to see, the different diagnoses that you make in clinic and when you have to triage them, kind of how we talked about it before. So clinic's awesome. Our clinics, we're very lucky to have some great PTs, OTs, and athletic trainers right around the corner. So it's cool to collaborate with them throughout the workday too, and all the time we update you on a patient and get your thoughts on the patient. So clinic is a really great part of the job, and it's one of the part of the jobs that I really enjoy, that when you talk to surgeons, they don't enjoy as much. There's procedures. People do procedures throughout their clinic day. Some people have dedicated procedure days. There's a ton of different variety and procedures that are popping up in sports medicine as ultrasound gets better, and some of the technologies that we have for treatment options get better. So, you have your ultrasound guided injections. A lot of sports docs do fluoro guided injections for the hip and the spine. Everything from steroids to prolotherapy and other orthobiologics like PRP and different quote unquote stem cell therapies or mesenchymal stem cell therapies. There's also some ultrasound guided surgeries that they're doing at different centers. This is a picture of a ultrasound guided loop carpal tunnel release that they do at the Mayo Clinic. Dr. Jeffrey Brawl is our trained doc that does hair. It's really cool procedure to see if people actually get back to work the same day compared to the traditional ultrasound guided, the traditional open or mini open carpal tunnel releases. In some cases, patients are going back to work that fast. So it's a really impressive procedure. And there's people, researching and trying other ultrasound guided, procedures like trigger finger release. There's people, doing research on these ultrasound guided surgeries for structures like the lateral ankle, these more superficial structures. So I think that part of the field is going to continue to grow as we go throughout our training. It's also possible to incorporate EMG into our practice. I don't know if anybody of you know who this is in the upper right corner. This is Dr. Ryan Nussbaum. He's one of my mentors stemming back to when he was a medical student, when he was involved with the AOCPMR. He's one of our sports medicine docs here at Pittsburgh. I met him first year down at a Hollywood CPM&R conference. So he argues that EMG is one of the most valuable tools that we bring to sports medicine as physiatrists, and he works really closely with hand surgeons to help them make different decisions. And there's a great tie-in with EMG and ultrasound as well. Dr. Michael Munin, who's one of our other doctors here, who's one of the big EMG docs, uses a ton of ultrasound. And when you see some of the structures that we're trying to stimulate, or read, and if you need some of the different invasive, EMG and NCS readers, here's the femoral nerve, here's the femoral artery, and here's the psoas, here's that nerve that we're trying to trigger. It's pretty close to other structures, and it's not the easiest thing, to find in the world. Or if you're sticking a needle in it, you're real close to some valuable real estate, or if you're sticking a needle close to it. So there's a great tie-in for EMG and ultrasound, and I haven't gotten to see much of it yet, but I'm excited to do it next year. Obviously, the part of sports medicine that everybody thinks of first is sideline coverage and the training room. And this is what makes sports medicine different than the other MSK subspecialties. Is you're right on the sideline, you're seeing the action, you're treating and triaging athletes, as things happen. And it poses a very unique challenge and is a lot of fun when you get to know your team and the different personalities, and you get to work hand in hand with the athletic trainers who really run the show and are amazing. It's an awesome experience. I highly recommend you all try and do it while you're in medical school if you have the opportunity, and definitely when you're a resident, seek out the opportunities. Even if you might not be completely interested in sports medicine, I think it's a really unique side of the field to see. So for us here at UPMC, we cover Duquesne women's sports. We cover basketball, volleyball, lacrosse, and soccer. We cover high school football. We cover the Penn Hills team, which is where Aaron Donald school. We cover West Mifflin. We cover the Pitts. Really awesome opportunity to do as a more junior resident. And then we get to cover obviously mass event coverage. We did with the Pittsburgh Marathon this weekend. I was involved with the medical team for the hand cycling division. These athletes were amazing. The winner came in a full marathon on the hand cycle, came in at like an hour and 15 minutes. So he was flying through the course. And then obviously I'm a huge wrestling nerd. This is my favorite wrestler of all time walking to the ring, Chris Jericho, an AEW event. And I got to, be in the training room after his match and check him out. I got to be ringside, and those are the type of opportunities that await you in the world of sports medicine. So with that, we'll take a quick break and we'll just see if there's any questions. Oh, Wendell's here. Wendell is our awesome at Pittsburgh. He bought me and my residency classmates lunch today. Any questions? I know I went through a lot of information, and I'll give you my email and everything at the end too. So if you don't feel comfortable asking now, there's plenty of other times.
We had a couple in our sign up link, if that's okay. I could just read them off to you.
Yeah. Are they like general sports medicine questions?
Yeah.
All right. Yeah, let's do that now then.
So the first one, it says, in the day of a life of a sports medicine doc, what do you see kind of field coverage versus in clinic? Like, what is the split? I know you mentioned a little bit about that, but.
Yeah. So in my limited experience so far, in my rotations in medical school and what I've gotten to do here so far, I'd say what you see on the sidelines, it depends what sport you're covering, and the level learning. You're going to see a lot of different things in like a master's marathon compared to high school football. But you're going to see a lot more of those acute injuries. Something happened right away, and now they're walking over to you on the sideline and asking you to check them out, whether it's concussions, ACL tears. I had a kid when I was covering a football game, one of my first football games solo, back pain with radiating pain down both of his legs, which was pretty scary. I covered a veterans hockey event. So these guys were like between their 40s and 50s and pretty high level hockey. It's the Warrior division of the USA Disability Hockey Festival. And I had a triage chest pain. This guy was having a troponin leak. So that's where you're going to see more of your triaging. You're making split second decisions whether people can continue or not. Specifically, like when you cover high school wrestling, you have, I think the clock is 3 minutes to make a decision whether an athlete can get back on the mat or not. You're actually on a clock. So it's high pressure situations, and it's more of those acute injuries. You might have some acute on-clonic flare-ups of tendinopathy and things like that, muscle strains, but mostly those acute, something happened and then you need to triage and figure out what to do about it. In the clinic, you could see those kind of things for sure. Whether it happened yesterday or 2 days ago, but you're going to see a lot more chronic things, tendinopathy, arthritis, back pain, and you're going to have to figure out different treatments and do more of, you're digging into their medical history, digging into the things that they already tried, digging into what kind of therapy they did and things like that. So there's definitely a little bit of a split between what you're going to see on the sidelines and the clinic, but there is some overlap.
No, that's great to hear. We have another question here. So I know you actually mentioned a lot of things you did as a medical student. Can you touch on a couple of those kind of experiences that kind of led you to PM&R and then thinking sports med and kind of that you saw it while in medical school?
Yeah. So like I said, I was lucky that I was selected to do the OMM scholarship at PCOM and spend an extra year in medical school. So, I had a lot of extra time to experiment. But the things that I would say were the biggest game changers for me, and I know I've seen a lot of you in AOCPMR pictures already in terms of going to the conference and stuff, is go to conferences and meet people. I think that is so valuable when you're slogging through studying for boards or COMLEX or STEP, when you're getting crushed by your different rotations that you might not be that interested in. It rejuvenates you. Seeing all these attendings who are happy where they are and are passionate about bringing people into the field gives you, it relights your candle and it re-energizes you, but it also gives you great connections. And I'm sure if you all went to the AOCPMR conference, you saw how friendly and inviting the physiatrists in the field are, and how they want to actively mentor you. So I think going to conferences, or if you can't go to conferences for whatever reason, I know it's hard in terms of cost, it's hard in terms of time. Try and make connections with local physiatrists and establish some strong mentors, whether they're, residents in the area, whether they're attendings in the area, whether they're family friends. It's great to have that sounding board, and it's great to talk to somebody who's been through what you have to go through, because it's a unique challenge. And I know a lot of you are coming from DO schools without a PM&R department like I did. And making those connections goes a long way. So I'd say that's the one thing that I recommend the most is finding mentors. There are two things that I recommend the most is finding mentors and going to conferences if you have the availability. The other thing is that, like I said, doing volunteering and doing sports medicine coverage, if you're able to do that, if you're able to spend some time in an inpatient rehab unit and make sure that it's something that you'd like to do while you're in residency, I think that's a great benefit as well. If you're able to score an inpatient rehab rotation as a medical student, I think it goes a long way, both in terms of what people are looking for in your application, what these program directors, assistant program directors, chief residents are looking for in your applications, and making sure you and the fields of the physiatry, but also making sure that it's something you like, because the last thing you want to do is get to residency and be miserable for that 50% of residency that you have to spend on the inpatient rehab unit. I'm on the inpatient SCI rehab unit right now, spinal cord injury rehab unit right now. Wendell sees me every day. I joke around that I'm miserable, but I promise I'm not. I love going to work every day. I love the patients that I work with. I love the doctors that I work with. And you need to make sure that that's, something that you could at least like. You don't need to love it, but it's something that you could at least like and do for 50% of your residency career.
That's great to hear. It's definitely, there's a different side that you're going to be a physiatrist at the end of the day, and sports medicine in addition to that. So it's great to hear that. Does anyone else have any questions? If you want to put it in the chat, or just unmute yourself real quick for Dr. Raum that he's here.
Can you talk a little bit about your extra year at PCOM doing the OMM?
Yeah. So Chris Conquest, that's a really cool name. So my extra year at PCOM, and it looks a little bit different at each different osteopathic school. Some of them do a year contiguously, and what you do during that year is different than what I did. Mine was 1 year that was split up into 4-month blocks and interspersed throughout my clinical education, throughout my third through fifth year. So I would go on rotations for a couple months. I would come back to PCOM. I would go on rotations for a couple months and then come back to PCOM to learn and teach. So I was actually, every morning I would see patients in the OMM clinic with one of the attendings. We used to rotate through the attendings that we worked with. In the afternoon, I was either teaching lectures or teaching in lab, or getting to see my own patients in OMM clinic, which is really unique and really cool. Some of them are a little bit more, academic focused, where you're doing a lot of teaching. Some of them are more clinical focused, where you're just really seeing patients. So PCOM had a nice mix of the two, and I think it really helped me frame my focus on wanting to do academic medicine and staying in academic medicine, but also being able to, figure out my other passions, like now the passion that I have for research.
Perfect. Thank you.
Amazing. Does anyone else have any other questions?
One quick one here. Dr. Raum, what's your experience with working with like adaptive sports and communities that, require like prosthetic fittings, and then working towards, even Special Olympics and that type of stuff?
Yeah. So we have a few different opportunities here at Pittsburgh, and there's different opportunities in every city. I know in Philly there was the Pennsylvania Center for Adaptive Sports, which is housed right up in Pennsylvania, and there's a lot of opportunities there. And if you're in the Pennsylvania area, I highly recommend that you Google them and you try and go to some of their events. It's PCAS, your Pennsylvania Center for Adaptive Sports. For here at Pittsburgh and the stuff that I've gotten to see so far, like I said, I covered the hand cyclists this weekend. They were mostly paraplegics for a variety of different reasons, whether it was something like spina bifida or something like a spinal cord injury earlier in their life, or amputees. So there was a few amputees there as well racing. We also do work with the Mighty Penguin sled hockey team. We had a fundraiser with them. We played against them in a sled hockey game. They're unbelievable, and we're getting involved more and more with some of the coverage for wheelchair rugby and wheelchair basketball here in Pittsburgh. In terms of like working with amputees and patients who are coming for specialized prosthetics and getting involved with sports, there is some of that in your clinic day, working with Dr. Unin, who's like a world leader in prosthetics, and working with Dr. McNevich, who has a really, really active amputee population. You get to see people get fitted for things like swim legs, things like cycling legs. And that's really cool to see, and really cool to see the prosthetist work through and teach you how to problem solve in terms of making a prosthetic that's going to allow a patient to do what they want. We spent time at Udin Prosthetics and Orthotics, which is a local prosthetic company. And there was a guy there who was an avid power lifter, and he had a specialized prosthetic foot that allowed him to squat over 500 pounds. And his challenge was to get to a weight where he would need the technology to advance for his level of strength. And he was getting pretty close. So it's awesome. Those opportunities are awesome. And that's something 100%, like I talked about EMG, that we bring to the field that nobody else can. That's something that we bring to the field that, none of the other specialties who do sports medicine are going to have the expertise that you do after physiatry training.
Thank you. If anyone else has any other questions, definitely speak now. But George, do you mind putting your contact information in the chat?
Yeah. So I will I have a slide, I'll put that up and everybody can take note of it. I know that you all have another event at 7, so I don't want to take up too much of your time. Let me do that now. If anybody has any questions, feel free to email, you can contact me on Twitter, whatever is easiest for you. I got involved with Med Twitter back in the day, and now I'm still on it. But these are just some of my sports medicine mentors. I wanted to highlight them quick. They're all awesome individuals, and I wouldn't be this interested in sports medicine if it wasn't for them. I'm going the wrong way. So just quick, I'll hammer home my take-home points before we get out of here. I do have a case, and if anybody's interested in the case, I could send out the slides. And if you have any questions about it, I'm more than happy to talk about it. Just goes through like building a sports differential or an MSK differential, and then a case that I saw with Dr. Schrader, who's one of my mentors. But take home PM&R residency, provide a strong medicine-based foundation. There's multiple options to get into an MSK career. And sports medicine provides many opportunities and challenges. Ultrasound is a great tool for the sports medicine physiatrist. Those are kind of the things that I just want you to get out of this. The last thing is mentorship is a critical part of the pathway. I tried to put many pictures of my mentors, and you see they're all over the country. They're some of the, I rely on them on an almost daily basis. So build your network of mentors and utilize them throughout the rest of your career. I mean, I texted Dr. Schrader, Allison Schrader, who was attending here last year. She was a fellow at Mayo Clinic, sports medicine trained. Now she's over in Cleveland. I texted her yesterday while I was putting together some of the stuff for this PowerPoint to figure out how to properly cite the patient case. So like even little things like that, it's great to have a mentor for. So this is my contact information. This is my dog, who luckily didn't bark throughout the entirety of this presentation. It's Levi. I put him at the end of every single point that I gather stemming. You can email me anytime. It's just George Raum, my name, med@gmail.com. You can shoot me a DM on Twitter. It's just @GeorgeRaumDO. And then, please, like any questions, no question is too small, whether it's about physiatry, whether it's about isolating mentors, whether it's about, life in Pittsburgh and life at UPMC. I'm more than happy to answer.
Thank you. Yeah, if you don't mind sending me this PowerPoint, I'll definitely send it out to everyone that came to this, and we'll definitely reach out for that.
Awesome.
Thank you so much.
Thanks for spending some time, everybody. I know you're all super busy, so I appreciate you coming and listening to me ramble.